Really, really excited for our second keynote, and it's a real privilege for me to introduce my friend and colleague, Dr. NIR URIEL, who's a professor of medicine, current director of heart failure, transplant, and MCS at University of Chicago. He completed his medicine training, initial cardiology training in Israel, followed by more critical care and advanced heart failure training at Columbia, where he became staff. And really has just had a tremendous career over the past several years, certainly recruited by University of Chicago to run that program, but just extraordinarily well published, over 150 peer-reviewed manuscripts, and has become and recognized as a thought leader in the field of MCS. He's currently one of the national PIs on the landmark momentum trial, the HeartMate 3. And he's put forth best practice, original investigative documents to guide us to manage LVAD patients. And so you can't have a meeting and not have Dr. NIR URIEL here when you're talking about MCS. So thank you, my friend. And I should highlight, he drove himself in multiple inches of snow to get to the airport because he didn't think that the taxi guy would get him there. So he's been through a lot to be here. Thank you.
So, good afternoon, everybody, and I have to say, it's a great, great honor. First of all, Jerry Estep is a dear friend, and whenever he said to me, "You come in," I didn't care about the snowstorm. I know that I'm going to be here in Texas. The only thing, I actually think I'm going to stay. It's much warmer, nicer here in Texas. And second, I just had a great lunch with your faculty here in Methodist, and this was absolutely great, just to hear how other people work and to be in a place that's where it all starts. So it's a great honor for me to be here today, and I'm going to do a big overview for you today. We're going to speak about the history of advanced heart failure, some recent studies and outcome. We'll speak about LVAD hemodynamic and dosing, and we'll speak about adverse event. So just a little bit of state of the art. I don't know if it's what it is, but we are going to start and dive in. So it all started many, many years ago. In 1927, there was a big event happened. Someone know what happened in 1927? Charles Lindbergh, who is he? The first pilot who flew across the Atlantic Ocean. He was an engineer. And as a pilot that flew across the Atlantic Ocean, he said, if we can build a machine that can fly across the Atlantic Ocean, we can build a machine that fixes a broken heart. And he started his idea, together with another, actually, scientist named Alexis Carrel, to build the first artificial heart. Here you can see it in an expo in Copenhagen, eventually reaching up to the Time magazine. And in 1938, they thought that artificial hearts can be from glass. So yes, heart is very broken, but we don't want it to be so physically broken. So this, of course, did not fly. But he was very involved in all the development of mechanical circulatory support, as you can see here. This model still exists, by the way, in the Rockefeller Museum in New York, so whenever you are visiting New York, if you're interested to see. Parallel to his understanding that maybe we can have machine fix a broken heart, there was other people that thought that we can do other stuff that will fix a broken heart, and it's going to be a transplant. The pioneer of this was Vladimir Demikov, actually a fascinating Russian PhD, not an MD, that was very involved in cardiac physiology and understand that we can connect organ from one animal to the other, and this can work. He was famous for one of his surgery that is not so popular, as you can see here, with the dog with the two heads. He took one head from one dog and connected to the other and showed that you can connect and create a transplant of that. However, Demikov was actually the pioneer of heart transplantation and other organ transplantation by showing that you can transplant from health. What I want to show to you that there was two parallel roads that started, one in the 30, one in the 40, to fix heart failure. One was mechanical, the other was transplant. Eventually, there was Dr. John Gibbon Jr. that he developed the real first heart pump machine. And this is the heart-lung machine that he developed in 1953 that opened those experiments that people thought can be only an idea on animals to be a reality. And together with people that actually sit down here in Houston, Domingo Liotta, that in his office in Baylor College of Medicine, was an engineer from Argentina that was working together with DeBakey in order to fix and to find a solution for heart failure. As you all know, it's all started here. And in 1964, the NIH decided, together with actually much higher level of decision, that as part of the Cold War, they wanted the United States would be the first one to develop artificial heart. During that time, to remind you, there was a real war going on between Russia and the United States. Russia successfully launched a missile into the space, and in response, of course, America wanted to be the first one to put a man on the moon. However, there was other aspect to this Cold War and achievement in science, and one of them to develop artificial heart. So in 1964, the NIH gave $500,000 to DeBakey to develop this artificial heart program. He was working with Liotta here, and in 1966, he performed aortic valve surgery on a young lady from New Mexico. As you can see here, the young lady is smiling right now. However, during the surgery, she could not be disconnected from the bypass machine. And because she could not be disconnected from the bypass machine, something needed to happen. And he said, you know what? Let's just put the LVAD that we developed. And she was the first one that, as you can see here, have the pump. She was supported for 10 days. In that time, her heart came back, and she recovered, and the LVAD was explanted. This was the first successful mechanical circulatory support on a human being. Parallel to that, a lot of advantage happened also on the people that believe that biological solution, as heart transplant, can happen. And there was a big race, a race between giants, surgical giants. Normal Shamway from Stanford that worked together with Richard Lawler from Virginia, Adrian Kantovich from New York, and a young surgeon from South Africa that did his rotation in Minnesota University, went back to South Africa, opened the heart surgery department in Cape Town, come back again to the United States to learn about heart transplantation from Richard Lawler. Over their times, there was doing kidney transplant over there, immunosuppression, and eventually, in 1967, December 3rd, exactly if you want to think about it, 50 years ago, Christian Bernard performed the first heart transplantation in this man that had ischemic cardiomyopathy. People actually asked the guy that received the first transplant, how did he agree to be the first person that received heart transplantation? And he said, for a dying man, it is not a difficult decision because he knows in the end, if a lion chases you to the bank of a river filled with crocodile, you will leap into the water, convinced you have a chance to swim to the other side. So this is the story of mechanical circulatory support and heart transplantation. Our patients are dying, and we are supposed to help them find a choice. I have to say, to the anniversary, I was invited to South Africa and I met the Christian Bernard family and actually other people that did the heart transplant in December 3rd. And I learned that it was even much more complex to do the first heart transplant in South Africa. Today, we have brain death. During that time, they didn't. So what they did, the lady that actually was the donor, it was a lady, she had a road accident, and she didn't die. But they thought that the injury is so bad, but they didn't know how to do a declaration of brain death. So they took her to the operating room, and they extubate her. And now she cannot breathe. So they waited until the heart stopped beating. And only then they declared her death. And only then they took her heart to donate it to this man. This man survived 18 days and unfortunately died from pneumonia. The team in South Africa thought that he had actually rejection, and they intensified the immunosuppression. However, he had a pneumonia, and he passed away after 18 days. And this, of course, was a big thing. Currently, if you Google it, there is two major achievements in the last century. And the two biggest scientific achievements of the last century, number one is actually flying to the moon, landing on the moon. And number two is counted as Christian Bernard performed the first heart transplantation. However, this was not such a success story in the beginning. And as you can see here from 1971, the tragic record of heart transplantation, every patient that they transplant die, one after the other after the other. People gave up. Adrian Kantovich, that performed the transplant in New York, actually the first transplant in the United States, stopped doing them. However, Norman Shumway and Richard Lawler continued to fight it, and only in the 80s, when cyclosporin was developed as immunosuppression, this changed. However, from here to there, today heart transplant offer an unbelievable outcome. And 50% of people that we transplant will survive at least 15 years, and some of them 20 and 30 years of heart transplantation. It's a great option, but it's limited. It's limited to only 3,000 people in the United States every year, in a good year. Most of the time, it's only 2,500. And because of that, the mechanical route that started in 1938 continued to grow. So from here to there, and I will jump on a lot because I could have done a full story because I'm really fascinated by the history of mechanical circulatory support and advanced heart failure. There was a generation change. In the beginning, when mechanical circulatory support that helped to go to this vacuum tried to mimic the real heart, to do the same. A heart has a pulse. It's filled with blood and it pushes the blood. And all the original mechanical circulatory support were pumps that fill with blood and push blood, pulsatile. However, because of that, and because those pumps work for 24 hours, 7 days a week, and they don't rest, machines are not as good as millions of years of evolution, and those valves and a lot of other stuff in them got destroyed. This all changed when one of the engineers went to India. And during his trip in India, he saw that water are being pulled up from a tunnel in order to move them to another tunnel via a very, very simple mechanical concept that's called Archimedes screw. An Archimedes screw is exactly what continuous flow LVAD is today. And this was the origination of the development of the continuous flow LVAD as we can see here. This is the first one that is continuous flow. It's the HeartMate 2. Inflow cannula in the left ventricle, a rotor that rotates in a speed of 8,000 to 14,000 revolutions per minute in between a magnetic field, sit on a bearing that have ruby stone, and push the blood into the ascending aorta. This motor is connected to a battery, a controller, and a battery that can last 12 hours. This was a game changer. So let's understand how grave advanced heart failure is. If we look at those two last curves, this is 12 months, this is 24. People with advanced heart failure die. 8% survival on optimal medical therapy. If you look at all those three curves, those represent the era of pulsatile pump. Overall, as you can see here, 25% 2-year survival. Much better than optimal medical therapy, but still not so good. And this represents the continuous flow era, 60% survival in 2 years. So if we want to think about it, medical therapy, 8%. Mechanical circulatory continuous flow, 60, it's 50%. There is a term that we always use, number needed to treat. So 100 divided to the absolute risk reduction, it's 50, meaning 2. We need to put 2 LVAD for 2 years to save 1 life. This is unreal. Just to put it in perspective, we need to put 10 CRTD for 2.5 years in order to save 1 life. So where are we today? Because I'm supposed to give the state of the art. So we have a lot of toys. We have the HeartMate 2, the original one, that is absolutely still a great tool to work. It's an axial flow pump, and it sits in the belly, as I showed you before. It's have a mechanical bearing. It can give up to 10 liters of support. We have the HVAD that I think you can see it outside. There is a boot. It's a pericardial device. It's centrifugal. It's directly, and we'll see it soon. It's hybrid magnetic and hydraulic, hydrodynamic. It's a little bit lighter. It's 160 grams. We have the Jarvik heart that is still in studies, that is intraventricular, inside the heart, as you can see here. We have the HeartMate 3, that is the new generation of the HeartMate 2, that actually go to become a centrifugal flow pump. It's magnetically levitated, also 220 pounds. It sits in the pericardial space, and we hopefully will have an MVAD. So let's go one by one and see where we are today. This is the HVAD that was evaluated originally in the advanced study, but I will jump into the destination therapy, the people that cannot get our transplantation. As you can see, the pump have an inflow cannula that sits directly on the apex of the heart. I have a motor that, as I said, it's partially magnetic, partially hydraulic, and it's a centrifugal flow pump. It's much, much smaller. It's only 160 pounds. The result of the endurance study was presented actually in Nice 3 years ago, and they show, that 57% of the people that get it not only will be alive, this time it's not only to be alive, were alive without disabling stroke on the original pump, no problem with the pump that we need to exchange it. 57%. So this was pretty impressive, but there was a lot of problem with stroke, and we will speak about it. And people that developed it thought maybe the stroke related to blood pressure. That was the signal from the advanced study. As a result, the endurance supplement was just presented a few months ago in ISHLT, and the result is really promising, and I think it's important to know them. So it was a 2-to-1 randomization, HVAD patient compared to HeartMate 2 patient. However, the HVAD patient have a blood pressure control arm. As you can see here, it's a classical LVAD patient population, very sick, 60 years old patient population. Intermax said the severity, how sick they are. The lower the number, the more sick you are. We can look at Intermax 1 and 2 are real cardiogenic shock, and Intermax 3 is people that are supported with inotropes. And as you can see here, and this is simplification of it, of course, 80% of the patients were very, very sick. The patient the HVAD patient had a lower blood pressure because they were in the blood pressure arm compared to the HeartMate 2 patient, and most of them were in a range of less than 85 millimeter mercury, 72% compared to 50%. What definitely they learned that they can reduce the stroke rate dramatically to 14.7%, that it will look very similar to the HeartMate 2. However, this is now 1 year survival, free of disabling stroke without any kind of need for device exchange. It was 76%. So it's not only to be alive, again, alive without a stroke. So this is a great result that was presented in the endurance supplement, and I think is going to be published soon in JACC Heart Failure. So definitely dramatic improvement with the HVAD. Parallel to that, there is the HeartMate 3. The HeartMate 3 come on a complete different philosophy. It's coming from a philosophy that I will simplify it, and I will say one of the things that we miss here, we're missing here in the United States good trains, because our trains go on rails. The train in Japan doesn't. They're called bullet train, and they go in a speed of 300 miles per hour because they are magnetic levitated. The train is not touching the rails. The same thing is the HeartMate 3. It's completely magnetic levitated. There is a magnetic field that is created, and the rotor is inside this magnetic field. It doesn't touch anything. So there is no friction, and it's not dependent on hydraulic. There is, beside that, a very wide gaps, so the blood is less damaged, and it's frictionless, and it sometimes increase and decrease the speed every 2 seconds in order to mimic the pulse, but actually most important, to wash the pump from any kind of difference. There is a big study that is conducted right now. It's called Momentum 3. And I had the pleasure to be the national PI of this study. And it's randomized 1-to-1 against the HeartMate 2. First, 294 patients to look at the patient if it's as good as in the short term, 6 months. Those patients will be continued to follow for 2 years, and then add to them 72 patients, and then eventually reaching 1,028. We finished recruiting the study actually very, very fast. We finished recruiting it in almost 15 months. And as a result, we add 500 more patients to a cap, continue access, and another cap. And now we're in the third cap. So the study eventually going to be 3,528 patients. I'm going to share with you the result of the short term that we just published in the New England in February. However, I can tell you that in March this year, meaning a month from now, we are going to present the gray box, the late result in the late breaking in the ACC. Again, very sick group of patients, as you can see, 60 years old, on a lot of inotropes, and 87% of the patients on nitrotrope. A lot of them are on balloon pump. And again, very similar. A lot of the patients are very advanced intermax, 2 to 3, 80% of the patients, meaning that they are shocky advanced heart failure patient, sick group of patients. This is the result of the Momentum 3. It's only 6 months. And as you can see, to be alive, again, without disabling stroke on the original pump was 86%. This was shocking, and this was very promising, very similar to the HVAD endurance supplement. And of course, it showed that we have now 2 pumps that are superior to the old pump that it seems to be very there. But what was more shocking in this, I'm sorry that it's moved a little bit, is that one of the adverse events that we're always afraid of in LVAD disappeared. It's called device thrombosis. 0 device thrombosis in the HeartMate 3 in this cohort compared to 10% in the HeartMate 2. And the rate of bleeding was very, very similar. So is it so good that we can open it into more people? So Jerry, Dr. Estep, did one of the seminal paper in a less sick group of patients. It's called the roadmap, actually the only study in less sick group of patients. This was the original report on the 1-year survival, and by purpose I choose this and not the 2-year survival because I want to use this one. Jerry, you know why? Because you're the first author on this. And it showed that people that receive LVAD, eventually 80% of them in 1 year were alive on the original plan. It's not that those people were dead, they just switched plan, but definitely it's raised the issue. This was done with the HeartMate 2. We're all fascinated to know what will happen if this will be done in the era of the HVAD or the HeartMate 3 that seems to be superior to the HeartMate 2. Is it all good? Unfortunately, no. And believe me, I can do this table even bigger. This is just summarizing the MACE study, the endurance supplement 1 year, the HeartMate 2 DT, the endurance, the regular study that is already published. This is, by the way, not officially published, and the Momentum 3 that is already published. And as you can see, a lot of GI bleeding, 15% in 6 months or 30% in 1 or 2 years, RV failure, and stroke. A lot of complication that we need to deal. So how can we deal with it? We deal with it because in front of me there is a pharmacist that's sitting, and this pharmacist will tell me, Nir, if you give lisinopril 2.5 milligram and you give lisinopril 20 milligram, it's not the same. And we just saw the Atlas study that was presented here that showed that those matter. And the Mocha study on the carvedilol that showed those matter. Does LVAD have a dose? I believe that yes. And the dose is a speed. So from now on, it's my interpretation, and feel free to ignore it, but we can see what we think. This is the current recommendation how to use LVAD. This is from the guidelines. We need to make sure that we make the speed set up so there is the septum is in the midline, and we minimize any kind of mitral regurgitation. We need to try to maintain the aortic valve opening. And yes, we need to give heart failure medication. But what is all this level of evidence? It's level of evidence C or B in a good case, meaning expert opinion. So let's look on the first thing that caused people with LVAD to come back to the hospital. Look, it's still cardiac. It's still the heart. So we still didn't fix their heart failure despite giving them an LVAD. So we developed this method, and Jerry as well, and his group develops a very similar method to do a ramp test. A way that we actually think about, let's think about this person and patient as half machine. And let's do things very mathematically, like engineers are doing, in order to overcome that. And we increase the speed of the LVAD from 8,000 revolution minute to 12,000 by 400 every 2 minutes. And we measure device parameters, echo parameters. We do the same for the HVAD. And we learn that the HeartMate 2 is very linear. I'm not going to go into the detail, but the size of the heart, whenever I'm increased the speed, the heart becomes smaller and smaller and smaller. It's sucked down. In very linear. In the HVAD, it's not so much linear. As a response for that, we try to understand, are those pumps affect the heart in different way? Should we address those dosing and learn it? So we are working in, I'm very fortunate to work with Roberto Lang, that is the Lang Book of Echo, is maybe the biggest echocardiographer in the world. And we decided to do this project together. This is a 2D echo that we transfer to a 3D transthoracic, and then we do a TomTech. Up to here, everybody can do this. It's something that is a software that we can do. And this is a software that we developed in the University of Chicago. It's called surface analysis. So from the 3D, we create a model of the inside of the heart. This is a real echo of a patient. And as you can see, we can really figure out how the heart looks and what is the shape of the heart. So now let's think about those LVAD. And if we want to know those dosing, maybe we can learn how they behave when we do it. So we did those ramp tests, and we did this technology during the ramp test. And I will summarize it in a brief, but this is what we found. This is HeartMate 2, this is HVAD, and this is HeartMate 3. Okay? First of all, the yellow here is very high speed. The gray is low speed. So when we increase the speed, you see what happened to the heart. There is a dose. It's not the same. We make the heart much, much smaller. In a longitudinal way in the HeartMate 2, this is the left side of the heart. In a global way in the HVAD, and the HeartMate 3 is somewhere in between. Okay? The HeartMate 3, the LV became shrink. That's shorter. That's something I still didn't figure out. The RV, on the other hand, became bigger. So it doesn't like so much the LVAD, as you can see, because it's an LVAD, it's not an RVAD, and it doesn't like to be ignored. And as you can see, the high speed is now the gray, and it's bigger than before. So when we go too high, in the HeartMate 2, it's much increased the speed, much less in the HeartMate 3 and the HVAD in that regard. When we measure two-dimensional echo, just remember one thing. We measure in here. So that's the reason the HVAD and the HeartMate 3 doesn't do such a decrease in the LVEDD. It doesn't mean that they don't change the shape or unload the ventricle. In order to prove that, we need to go to the cath lab. And this is the way we do the ramp. We do all our ramp in the cath lab with an echo. This is my partner, Gabriel Sayer, and myself. We do a ramp on an hemodynamic ramp on those patients, and we learn. See, there is a clear dose. When we increase the speed, the PA-SAT improves, both devices, and meaning that the cardiac output is higher of the patient. And as a result of that, the wedge is going down. So we unload the ventricle with both devices, very, very similar, as you can see here. Furthermore, we decide to plot our patient on a 2-on-2 table and to understand where they are. If the CVP is below 12 and the wedge is below 18, they're in the green zone. That's where we want them. But look, 50% of them were not. By manipulating speed and afterload, we can take those patients here. So there is a dose that you need to learn how to adjust in order to put a patient in a good hemodynamic state. But Jerry will say to me, but Nir, is it important? So this is new data. Nobody saw it before. It's going to be actually officially presented in the coming ISHLT. This is what happened when you optimize patient. This is 88 consecutive patient prospective data collection for 1 year. If you optimize patient, it's almost 50% reduction in readmission, total readmission, mostly due to reduction in the heart failure readmission that I showed to you, that is the #1 cause. But almost all the others are also lower. This is the freedom from to be alive without any readmission if you are optimized or not optimized. So we better use those doses. So pharmacists, you also have to work with the LVAD, the dose. Okay? However, it's not so fun to do a cath lab all the time. It can be complicated. So let's take the HVAD as an example. And the HVAD as an example, I'm not going to go into all the technology behind that, but the flow inside the pump is dependent on very simple thing. The ratio between the inflow cannula, the pressure that the inflow cannula is see, and the pressure in the outflow cannula. Because this is what the pump's supposed to pump against. It has a fixed speed. So if there is a big delta of pressure, this fixed speed will do less flow. If there is a small delta of pressure, this big same speed will do more flow. So this is the main concept of mechanical circulatory support. How does it look on the screen? It looks like that. That's how a HVAD, and I really recommend that people will screen look like. So we thought maybe we can know the hemodynamic from this screen, because we have the flow, and the flow tells us pressure. And what we do in the right heart cath, we do pressure. So we took this, we did very primitively, we took those lines, and we took a picture with the iPhone, and we magnified this line. And when we magnified this line, we learned that there is 3 phases. There is a phase that it's going up, meaning that the flow is becoming higher, meaning that this is the systolic phase, because in systole, the pressure inside the ventricle is high, and it's coming close to the pressure in the aorta. When the pressure starts to go down, it's the diastole. And there is a small phase here that is the ventricular filling phase. It's the end of the diastole. The ventricle starts to fill it. And we start analyzing all those lines side by side with hemodynamic, and we learn that the slope of this is actually tell us what is the wedge of this patient. And I'm simplifying a lot here, but eventually what we learn that if the slope is more than 5.8, probably the wedge is above 18. And you can see sensitivity of 87% and specificity of 95%. This is just to show you that the pulsatility doesn't mean anything. Okay? So we actually maybe don't need to do right heart cath. We can do it. And this is just to show you, because we do it now on all our HVAD patients. We actually look at the slope, and we know that with the speed change, we can actually change the wedge pressure of the patient without taking them to the cath lab. But is it so simple? No, it's not so simple. This is just to show you another example, because there is more to it. It's not only the wedge, it's not only the PA. We had a phenomenal session here about pulmonary hypertension that I personally really, really enjoyed, both the case and the teaching point of it. But in pulmonary hypertension, we always speak about decoupling between the PA diastolic and the wedge. And I remember, because I'm a lot of time in the cath lab, like Jerry, and I'm calling my team, why the PA diastolic and the wedge are so different? They are WHO class 2. Why it's so different? And we decided to look why it's so different and if it matters. And we learned that 50% of the patient have a decoupling of more than 5. We choose 5 and not 7 because this is what the ROC analysis tells us. And we decide to go with it. And then what we learn, if you don't have a decoupling, and again, I'm simplifying it, it's much more complex. If you don't have a decoupling, meaning the wedge and the PA pressure really look the same. You not only that you're alive, you don't have any heart failure readmission. If you have decoupling, you can unload the ventricle, but the pulmonary bed did not reverse remodel, probably. And I'm not going to get to the pulmonary reverse remodeling. You have a lot of heart failure readmission. And now we're working with it. We have a study that we actually give in the cath lab, phosphodiesterase inhibitor, in order to assess what actually happened and can we manipulate it and can it reduce heart failure readmission. But heart failure readmission is not only because of that. It's because LVAD can cause a lot of other trouble. And the other trouble that it can cause aortic insufficiency. As you can see here, in 12 months, 75% of the patient will develop some degree of aortic insufficiency. However, only 8% will be significant in 1 year. The more time that passes, the more aortic insufficiency those patients will develop. Why they develop it? Because the aortic valve, we don't use it, so it became closed all the time. And then it became fused, as you can see here. Eventually, we need to open the aortic valve. This is one of the papers that we did, and we show that the aortic valve opening associated with less AI compared to people with aortic valve that is closed. And this is, again, go to the dose. How you adjust this LVAD speed. So what we think happening, why those patients develop AI, they have high continuous flow LVAD. It's increased the pressure in the aorta, decreased the pressure in the LV, and then the aortic valve is closed. The commissure are fused, and there is a deterioration of the leaflet and eventually develop aortic insufficiency. Does it matter? I thought it's matter because if blood is dropping back to the ventricle, it's a closed circle, so the LVAD doesn't do anything. However, one of my colleagues, a phenomenal heart failure specialist, that is a friend of both Jerry and I, Jennifer Kauger, said, no, it doesn't matter. And we saw that it matters, she saw that it doesn't matter, and I decided to leave Colombia, and we said, okay, let's sort this once and for all. And we thought maybe we are wrong. We are looking at aortic insufficiency through the aortic valve in a patient that have aortic insufficiency not only in the diastolic period, rather than also in the systolic period, pan-cyclic AI. So maybe the regurgitant fraction is completely different, and maybe we need to assess it differently. So we decide to go back to the root of aortic insufficiency and to do regurgitant fraction in the cath lab on every patient with LVAD and to assess them. What we learned was fascinating. We learned that if, and then we gave again the echocardiographer to read, if they didn't see any AI, really there was no regurgitant fraction. If they saw trace to mild AI, the average regurgitant fraction was 40%. That is moderate or moderate to severe. Okay? So we understand that regular echo is not the same for those LVAD patients. And what I'm going to say from now on, I just want you to remember that. Whatever we know about general cardiology, we cannot just say it's applicable to LVAD because they are different beasts. It's a new story. And eventually we came out with a new criteria that is based on the outflow cannula that say actually how much afterload you have, because if you have AI, you have less afterload. So you're going to, when you have less afterload, you have to have much more flow. So I'm not going to go to the complexity of it, but we assess now aortic insufficiency in the outflow cannula. And this is just to show this is much more accurate. This is with regurgitant fraction, 0.91 correlation compared to 0.06 of the regular echo criteria. And if we do that, we learn that patients that have AI are really suffering much more. So we think that this gives us an explanation why there was different, because we didn't appreciate the AI appropriately. And this is something that we need to remember. And I'm going to jump over this for the sake of time. Can we solve this AI? We think that we can solve this AI by maintaining the aortic valve opening and blood pressure control. So how can we open this AI? If the pump is going up and down the speed, like the HVAD in Europe have a LVAS cycle and the HeartMate 3 have, maybe we can make something that's called co-pulsation, smarter pump that will speak with the pacemaker and know when to increase and decrease the speed. And by doing so, we can prevent AI because the aortic valve will open in the right time because the speed is going to go down, so there will be less pressure when the heart is contracted. So this is one thing that we work with the engineer in order to try to see if it's open. But maybe we can fix the blood pressure. So again, this is a toy that I have to say we developed with a bunch of a friend of mine from Israel that we thought that, I told them they are completely off from the medical field, that we have a problem, we can't even measure the blood pressure, and this is the afterload, and because of that, they develop AI. So what's the problem? We can do that. And we finish now, and I start to explain to them that the problem is this, that LVAD patient, you see, they don't have a blood pressure. They have 90/80. They don't have delta blood pressure, and that's the reason we cannot measure those blood pressure. However, with the technology that they developed for us, this is simultaneous arterial line and the live metric, and as you can see, it's almost one-on-one. And look at the blood pressure here is 85/80. This patient didn't have anything. We simultaneously streamline. We just finished the pilot study in University of Chicago of 8 patients, and I'm just going to show you the correlation. It's bit-to-bit analysis, it's 0.92. It's a non-invasive arterial line. That's what it is, non-invasive arterial line. 0.92 for the systolic, 0.86 for the diastolic. And maybe that will help us to reduce AI, but also to treat other adverse events. I'm going to fly very fast on the last thing that I want to mention, but on one hand, we had a clotting. I didn't put a lot of attention this talk to clotting because I think it's slowly the device thrombosis is coming down due to the PREVENT study and the HeartMate 3 study and the HVAD. It was never very high. So, but bleeding was always a big problem. And it's a big problem that happened all across. If you're 6 months out, if you're 2 years out. And specifically if you're older, you bleed more. So do we have any other people that bleed in cardiology? Yes. It's called aortic stenosis. And Head, in 1954, actually in a letter to the New England, this is only a letter, he described a patient with aortic stenosis that have acquired von Willebrand disease and AV malformation, and he bleeds from that. And the von Willebrand that's responsible to the aggregation of platelets and adhesion into the lesion, the high molecular are being destroyed due to the high shear stress in the aortic stenosis. If this is high shear stress, what is just I show you in the Archimedes screw? This is much higher shear stress. So we checked that, and in 2010, we reported that 100% of the people with HeartMate 2 have acquired von Willebrand disease, and after we transplant those people, it's disappeared, meaning that the LVAD is causing this. Sherry Crow demonstrated it's higher. This was after 2 cases reported from Vienna that demonstrate acquired von Willebrand disease in some LVAD patient. So maybe it's pulsatility, maybe again, because we have something non-physiological. We ignore the pulse. And Omar Pinzon showed that people with more pulsatility have less GI bleeding compared to people with low pulsatility. They have high GI bleeding. However, maybe it's not that. And there was mounting amount of evidence that it's angiogenesis. A close friend of mine and my mentor, Dr. Uli Yorde, demonstrated that heart failure patients have a lot of angiodysplasia already in the nose, meaning probably all over the gut. And it's much more common in LVAD patients. So we decided to take it, and I'm not going to go through all of it, into the basic, and really to show you that we really, when we treat LVAD patients, if we want to be at the state of the heart, we need to redefine physiology because they have a different physiology. So how blood vessels, I'm going to do it very fast, how blood vessels are going to be performed? They created because we have VEGF. And this VEGF is connected to something that's called angiopoietin 1, the good agent. When they connected, they build normal blood vessel. There is the angiopoietin 2 that kick out the angiopoietin 1. And if we link to the VEGF, it's going to be abnormal angiogenesis. Very, very simple. Where they sit? They sit in the endothel. So this is the endothelial cell. The endothelial cell is being fed by a cell that's called parasite. This parasite secretes the angiopoietin 1, the good agent. Inside the endothelial cell, there is the Weber poly body. In this Weber poly body, we have the von Willebrand that we just said that is always destroyed, so we spill it to the blood. But unfortunately, in the same space, there is also the angiopoietin 2. It sits on the same vacuole. So whenever the von Willebrand is being destroyed, and we need to fill it in the blood, we spill also angiopoietin 2 that is going to kick the angiopoietin 1 and create bad thing. So we start to check those levels in LVAD patient, in heart failure patient, in transplant patient. It's 50 in each one of the groups. And we demonstrate that the angiopoietin 2 is much higher. The bad guy is higher in LVAD. The good guy is lower in LVAD. We didn't put transplant on angiopoietin 1 because prograph affect angiopoietin 1. And then we decide, wow, so they have a lot of angiopoietin 2. This is what causing all the problem? And apparently what we decided of doing, to take a metrogel, a gel that on top of it we have endothelial cell, and to put the blood from an LVAD patient. And when we put the blood of an LVAD patient, heart failure patient, we can check how much blood vessels are being created. As you can see here, this is heart failure patient. You see big blood vessel. Transplant patient, big. LVAD patient, a lot of blood vessels that are very small. So we decide, let's block this angiopoietin 2 and see what happened. Nothing happened to the heart failure because they didn't have a lot of angiopoietin 2. Nothing happened to the transplant, but the LVAD patient normalized. So if they normalize, maybe this is the reason they create blood vessels. The more angiopoietin 2 we had, we saw that they create more bad blood vessels. And we found out the same with TNF-alpha. And I'm going to write it because the reason we went to TNF-alpha, because you remember the parasite that feed the cell, is secrete angiopoietin 1, if we have a lot of TNF-alpha, it kills this parasite and we'll have less angiopoietin 1. So we decided to give TNF-alpha blocker, and we saw that we're killing less parasites. And eventually we have less progression of the angiopoietin 1. And then, let's take now what we learned to the clinic. I said, patients are bleeding. And we said, if the patient have high angiopoietin 2 and they have high TNF-alpha, boom, they bleed. However, if not, they did not bleed. But you will say to me, this is happening only in Chicago because of your snow and everything. So we decided to take this into a prevent study. This is a 26-patient study. Again, I'm giving you a glimpse on new thing that's going to happen only in the coming ISHLT in April. Okay? This is 23 sites, 300 patients. Eventually, what you can see here, that if you have high angiopoietin 2 and high TNF-alpha, this is your freedom from bleeding. If not, this is your freedom. So this is completely applicable now to Houston and Dallas and Austin, wherever you want to be in Texas, meaning this is the way that we need to address. So can we treat this? It may be simpler than we think. What suppressed TNF-alpha? Omega-3. And the reason we thought about it, because every time I travel to Japan, I'm shocked that the GI bleeding rate is 3% and ours is 30%. But every time I travel to Japan, I'm amazed by the sushi and the fish and everything. So we decided to check, and we gave 4 grams of omega-3 to 30 patients, consecutive patients. Their 1-year GI bleeding was 7.7%, almost like the Japanese, compared to 30. So now we are conducting a randomized study. This is also going to be presented, a randomized study about omega-3 to prevent GI bleeding. And again, I know that there was a pharmacist panel about natural things to heart failure. All my heart failure patients are on omega-3. I'm a big believer in omega-3. Okay? But I'm not going to go into it. But also the LVAD now, not only the heart failure. And now I'm starting the transplant. It's a good drug. And it's a food supplement, but it's a drug. So if we combine all of it together, eventually what we can see that there is a lot of adverse event in LVAD. And there is a new score that we developed, and I'm not going to speak of it. But I want to remind you all, LVAD is not perfect. There is a lot of adverse event, but it can fit to male and female, to young and old, to big and small, to people that have a coagulation problem and people that don't, people that have a history of stroke, history of GI bleeding, and yes, also to Jehovah's Witness. It's just going to cause your coronary to spasm sometime when you have GI bleeding and hemoglobin go to 3, but still, you can handle it. So the last thing I want to do in order to finish, to challenge us together. Wherever we believe, whoever is the God that we believe, created us with pulse, and now we don't have pulse. Does it matter? So a few years ago, I was challenged by one of my patients, and I have to say, this is so good because it really was a humbling experience. She was so much smarter than me. And this was a young patient that had HIV, and that's the reason she was referred to me, because I'm doing HIV transplant. And she had postpartum cardiomyopathy. And they sent it to me, but she was a psychosocial mess. She just after delivery, she didn't have any support. And I said, no way she's going to have a transplant right now. But I'm willing to put an LVAD into her. So we decided, the LVAD coordinator said, no, she's really a mess. And she was a mess. We put an LVAD, and she ran the battery out, and she had a driveline infection, and she had so many things. And 3 years on the LVAD, she came to my clinic, and she said, Nir? I said, yes, what's going on down? I'm pregnant. I was like, what? And I didn't know that you can have sex with an LVAD. I didn't know what's going on. But I said, wow, I didn't know what to do. Immediately I said, what we need to do is probably an abortion. Because you have acquired von Willebrand disease. We don't know how the baby is going to develop without a pulse, what it's going to do to organogenesis. We didn't know anything. She said, look at me, I'm going to have this baby, and we need to understand how we are going to do this. So what we did a lot of changing the speed because it's have a dose, so they need more cardiac output, and we increase the speed when the pregnancy went on. And we have a death list who is going to be the attending cardiology because the OBGYN said, we decide with them it's going to be a vaginal delivery. That they're going to deliver the baby only if the cardiology is going to be. And I said, what, the baby is not going to go out if cardiology is not going to be in the room? But we decided, okay, we'll go with them. We had a death list. Lucky it was not me, by the way. It was one of my colleagues because the labor itself took place 34 hours. And we really changed the speed. We had a swan, we changed the speed with all the phases. And eventually, a new baby came. And the baby was completely normal, and is completely normal. And Yvonne became an amazing mother to this second child, not the one that was the postpartum. And she grew up to be eventually a transplant candidate after this experience. We grew up to be a physician that understands that you need to listen to your patient and you need to do what she wants and to go with what your patient wants. But we as a community learn that you don't need a pulse in order to be productive. You don't need a pulse for organogenesis. And during LVAD support, not only that you can save the life of your patient, sometimes you can even create a new life. So thank you very much, and I will be happy to answer any questions.
So as always, excellent talk. And let's jump right into questions.
Any question?
So while the audience is deciding on, we'll start with Jonathan.
Jonathan.
So you're talking about the VEGF, medicine along with the TNF alpha drugs. Could you theoretically, are you hoping to say that we can hang a cancer drug or give a sub-Q cancer drug to maybe stop angiogenesis and reduce the bleed? Is that kind of the direction you're thinking that this may go?
So I will even give you a couple of hints. Amgen have an angiopoietin 2 blocker that they're currently checking for malignancies because angiogenesis is a lot of the new therapy for cancer is anti-angiogenesis. And unfortunately, they refused to talk to us because they want first to get the medication approved to cancer. As you know, this is where the big bucks here. When they give the medication to cancer, they get much more money. And only then they will consider to do an orphan indication. I think that we can attach. I have much more data to show about angiogenesis. We actually measure 18 different angiogenesis pathway and different inflammatory pathway. And maybe we can go behind it, but yes, it may be worth looking at, but unfortunately none of the angiopoietin 2 blocker is available already as an FDA approved. And when they will be approved, they first go to the oncology population and only then to our population, probably. But we are speaking with a couple of the companies already. Yes?
Thank you so much. Really enjoyed the talk. Your point about the decoupling, uncoupling, this is something that we have been discussing and recognizing the severe problem. So on your analysis that you presented, wondered if you had accounted for GFR in some of your calculations, how much that was part of the realization and the whole outcome. The second thing is, if you have any projections and thoughts and studies as to how to perhaps mitigate, pre-treat, how to get through, and perhaps put the patient as a better candidate after, post that.
Okay, so actually, great question, both of them. In regard to the analysis, I just showed there is a couple of papers that we did in decoupling, and this is from the first one. It's very simplistic. We just try to see if people have decoupling, what is their outcome, not adjusted to the creatinine, not adjusted to anything. I can tell you that the patient population were pretty similar. In regard to the second point, I think eventually we're going to put the LVAD into a lot of patients that are higher risk and lower risk. The challenge that we're doing is that we don't adjust it appropriately. We really use global thing. Okay, speed of 52 to 5600 will be a good speed in the HeartMate free, and I'm the one to blame on that, you know that, but I'm saying there is the nuance. And the nuance going to personalized medicine that include a lot of pharmacology inside of it, because I really think the afterload play a key role. So again, from shortage of time and a lot of things, originally I had 180 slides for this talk, and then I will say, oh, you will stay until tomorrow, but I didn't want to do it. But for example, we have a study that we just launched, the first patient, it's the first in the world that received oral milrinone. And again, this is a medication from the 80s, that the VEST study was a negative study, but those patients was not in the beta blocker era, not in the ICD era, and of course, have 25% of the people in the study was angina. LVAD patient doesn't die from arrhythmia. So we said, let's help the right ventricle and the afterload with oral milrinone. We found a company in Australia that produce oral milrinone for horses. And together with the FDA, we get approved to do the first in-man study in the United States. So I can tell you we just launched the first patient this week. The first patient was recruited this week. And I will tell you in 2 weeks how he is, because we have every 2 weeks a hemodynamic. But I think together medication and speed, you can get a lot of patients out of trouble. You see it. 50% reduction in overall readmission. 50%. It's not 10%. It's not 20. 50. And the p-value already in 80 patients. We have now a randomized study called Ramp It Up. And this is only for HVAD that we do with hemodynamic adjustment versus not hemodynamic adjustment. We finished enrolling already 28 patients. It's a pilot, so it's supposed to be only 40. So 12 patients from now will be done. And I can tell you in a randomized way how it's look. Yes.
Excellent work, scientifically amazing stimulation for the entire field. I think we have to applaud you for everything. I'm particularly interested in your angiogenesis work that you did. We looked at our LAD samples of patients who get an LVAD and get a transplant and compared them to heart failure. In the LAD samples, presuming they're seeing continuous flow, they're no different than heart failure. But then when you look at the smaller vessels in the pulp, we have a non-invasive testing that looks like the endothelial function is worse. So my question to you is, do you think that it is the small vessels that are more of a culprit than the large vessels, and they behave differently, and how do you solve that part?
Wow, first of all, your study is fascinating, and I will be very interested to see it and to read it. I think it's important. Angiogenesis is all different levels of vessels, from the big to the small. We also encountered that there is a reduction in the endothelial function in patients with mechanical circulatory support. And I think it's more time. The way I look at LVAD is accelerated vascular aging. I think all the vessels became aged more fast in a faster time. In relation to the angiogenesis is actually a process that we now know that is abnormal not only in the LVAD patient, actually in the heart failure patient itself. So there is something in the congestion that creates a situation that we have abnormal blood vessels, usually the small and the even microscopic level blood vessel that we see this angiogenesis going into. However, the study that Uli did in Montefiore, and they scoped the nose of advanced heart failure patients, they showed that they already have a lot of angiodysplasia. If you have LVAD, those angiodysplasia became much more profound, but it's much more than normal people already in the heart failure. So I think all the condition is a condition that increase dramatically the angiogenesis. But it's mostly small vessel and tinier.
There's one question being texted in. I'm going to read it directly. You've addressed it, but if you can just give us your response. How can you make an estimation of the wedge pressure from the LVAD waveform when the waveform itself is a calculation based on the patient's preload and
Afterload.
A meaning afterload?
Afterload. So first of all, it's a great question, and thank you for this question. And we need to remember that this is correct. The flow is an estimation that comes from the power. Actually, this study originally was a power study. The reason that we choose to analyze the flow because it was the waveform is easier to magnify. Now, eventually it's the same. The power and the flow go hand to hand in any centrifugal flow pump. This will not be true to axial flow pump, okay? So it has to be very clear that we're talking now only in centrifugal flow pump. that have to be HVAD or HeartMate free. In the HVAD, you have the waveform available from the screen. In the HeartMate free, you have it in the back end, and we're working with the engineer over there to get them. But definitely, you can use that. Now, you need to understand it's an estimation. This is not a linear correlation. By purpose, I didn't show you an equation that you can tell, oh, this slope is a wedge of 18, this slope is a wedge of 25. Because we also learn, and there is a parallel study by Chris Hayward from Australia that have the data logger, that is even much more accurate than our iPhone, that we do the picture, that show that this relationship is actually like a parabola. And the equation itself is not completely clear, but what we can definitely do is do cutoff, and that's the reason we decide to go with the dichotomal analysis. I just want to know, is this patient unloaded or not? This is something that is not as accurate, so we understand and accept, and I agree with the limitation. I'm not going to give you a number of a wedge. I'm not just going to say this wedge is higher than 18. Yes, Jonathan?
This will be last question.
Last one, I swear.
I'm here. You can ask me after that.
Okay, so we've had some. There's cases where we've had, and other institutions have had off-label use of an HVAD or some other VAD for the right ventricle, and you talk about like uncoupling and evening out the pressures on the right and left. Yet we're not really there for the BiVAD portion. And I was kind of wondering what your thoughts are based on like using a ramp and ramp study to like equalize the pressures on both sides to help it work. Is that actually feasible, or is it just the geometry is not there? Or?
Unfortunately, LVAD will never be something perfect for the right side. I spare some slide on hemodynamic. Jerry actually knows them very well. That the CVP is not affected so much on the acute setting when you increase the speed. It's going to affect on the long side, but the volume is. So it's meaning that eventually it will affect. Unfortunately, I think you can do some optimization. If it's a full-blown RV failure, you will need to do other style of work around it. And that's the reason, for example, we choose the oral metronome to support it. I actually more optimistic than you about the BiVAD, and I think there are closures than we think. I think that the understanding that LVAD is wonderful and amazing, but we cannot create a fontan-like circulation to all the patient, and we need two ventricles to work. Most of the people, the degree of the cardiomyopathy on the right side is sufficient enough that LVAD will be good enough. However, the minority of them, some of them will need a biventricular support. I think the study on the bivacor is going to start here in Houston. And is it your hospital or what? Bivacor? No. No, so probably it's one of the other competitor in the city.
Thanks for letting us know.
There is a bivacor device that is actually one pump that rotated from one side to the other, and by that given continuous flow device to both sides of the heart with one controller and one set of batteries. So I don't think, and there is another one that's going to be in Cleveland, actually. The Cleveland Clinic have a biventricular continuous flow support that is also going to be. So I truly believe it's going to be there. And I just show you a development of technology from 2004 to 2018, 14 years, from the HeartMate 2 to HVAD and HeartMate 3, and what big of a jump we did. I think that if in another 14 years, this will be like ancient thing for us, like the iPhone now look compared to the old phone that we had.
Do you think it'll ever replace transplant?
You had one question. Thank you, my friend.
Thank you.